guys, welcome to a quick coaching session with me. So I've had this case sent to me by a dentist who would like my opinion. And he's concerned, so patient's concern is actually about the crowding and protrusion as well as the lower midline shift. Young female patient. And if we look at it from the sides, you can see it's a class 1 on the right side and a half unit class 2 on the left side. So your typical class 2 subdivision. But here's the thing. The patient has pretty much severe Bimax protrusion, or some might say moderate. I think it's pretty severe given that we are starting to see bone loss. Now, this is a CBCT that's integrated into this plan, and you can see that there is generalized horizontal bone loss, and we're looking into a little bit of scary territory when it comes to your lower incisors, right? So in these cases, what do? How do we resolve the crowding? How do we get the lower midline to coincide? Because that is the patient's concern. Luckily for this patient, I don't see a lot of gingival recession. But that's not to say that the periodontium has great support and that we must not, we ignore that. So let's have a look at what Invisalign has done. Now, Invisalign obviously has given this simulation based on the doctor's preferences, which was to not expand the arches laterally and to align the teeth, and while aligning it, also reduce the deep bite. And obviously, it's showing that you're going to end up in a lot of dehiscences, if you do that, because it is a Bimax protrusive case. So how else are we going to find the space? So this is a classic case where we need to consider the effect of incisor protrusion. Incisor protrusion is a type of dental crowding. Just because they're flared forward and look aligned doesn't mean they're not severely crowded. So protrusion is another phase of crowding. So when we see such severe protrusion, really, I think this patient's calling out for extraction. Now, it may seem because there's no crowding, some people think no extraction, but if we were to align the teeth, you can see what's happening. You can see that, no matter, even if we did some IPR, which is interproximal reduction in this case, we're still ending up with relatively retracted upper incisors, but really proclined lower incisors. So my suggestion to this dentist is that this is not a non-extraction case. I think this is an extraction case. Even though there's spacing here, I would be extracting upper fours. So upper fours, or we won't go into that. Sometimes I will do upper fives too. But upper fours, okay, here, which is classic way, and it will help me retract the upper incisors. Now, I'm not going to retract them 100% into the premolar space. It would be retracted at about 50%, 60%. So it's a reciprocal anchorage situation where I would actually retract my anteriors halfway and then possibly mesialize this, but probably 40% posterior mesialization, 60% anterior retraction is what we'll look at. But in the lower arch, we do something differential, something different to correct that midline. So we would remove this 5 instead of a 4, which is your classical class 2 extraction pattern, to allow this mandibular molar to come forward into a class 1. And on this side, we would extract a 4 to actually allow that lower midline, which is quite off towards the patient's left, to move towards patient's right. So we would do upper 1 4 2 4, lower 3 5 4 5 4 4. So doing that will help us correct for crowding. It would, which protrusion is another form of crowding. It will help us, retract her teeth somewhat into healthier bone, where bone is a little bit more dense, and stop creation of any sort of dehiscences. It will also allow correction of a class 2 to class 1, which was patients wanting. Now, an alternative is extensive IPR. Now, that by extensive IPR means I don't think we're going to be able to resolve anything. You'd have to do at least 0.5 millimeter interproximal reduction of enamel across several teeth, maybe even the, your premolars, across premolars and anteriors. Now, that that could assist somewhat, but it's not going to create a whole amount of space for retraction. So we think somehow IPR magically will do it all, but IPR is generally quite a minimalistic way of creating space in the arch. So this is my recommendation. I think it's a clear-cut extraction case in my opinion, and this is what I have told the dentist: to resolve patient's crowding, protrusion, as well as change the lower midline. Extractions are necessary in this case. And in this particular case, CBCT was really helpful in me changing my mind on whether we could get away with a compromise result and some interproximal reduction, or should we do extraction. And I think the CBCT data here helped me to treatment plan this case more towards an extraction pattern than non-extraction. I hope this was helpful to you guys, and keep watching me on our YouTube channel at Boss Ortho. I look forward to our next session and next video. Bye guys. See ya.